Hello again everyone, this is Dr. Habib and welcome back to the channel. Today we'll learn about interpretation of chest x-rays and I hope you find this video useful. So before we move on to interpreting the x-ray, let's cover some of the basics in brief detail. So there's three types of films that are usually done for the chest: the PA film, the AP, and lastly the lateral. PA stands for posterior anterior, and as the term suggests, the beams of the X-ray are passed from the patient's posterior side moving on to the front. The advantage of this method is that the heart size is not exaggerated. In an AP film, the patient is quite unwell and usually bedbound, so the radiographers come directly onto the ward and direct the X-rays to the patient's chest, and this is picked up on a plate which is at the back of the patient. The disadvantage being the heart size is exaggerated in this case. And lastly, lateral films, but we won't be discussing these in today's talk. The amount of ionizing radiation per single X-ray is 0.1 millisieverts. This is considered negligible for causing cancer. We have different color variations on a chest X-ray, ranging from white to black, and these are quite important to remember, and this will help you in interpreting pathologies on an X-ray. This is directly proportional to the amount of ionizing radiation that is absorbed by the different body tissue, and this ultimately depends on the density of that body part. So for instance, bone has the highest density because of the calcium content, and they will absorb the majority of the X-ray beams, and that's why they appear white. Bright white is shown up by metals such as pacemakers or any, say, foreign body in the upper aerodigestive tract. Black is for air because air is not going to absorb any radiation. And then we have fat, which appears dark grey, and then we have water or fluids which will appear light grey, and you'll see these in the next slide. So this is a PA film, and many people have different methods of interpreting the X-ray, and I've got the most common one used, which is the ABCDE method, and some people use F and G, but for simplicity I've decided to add everything else in the E category. So if you have a systematic approach, you're going to be thorough and not going to miss out any important things. In terms of patient assessment, we'll make sure that the right details are present in the top right corner usually: name, date of birth, hospital ID, etc. We'll then look at the right or left marker. So the left marker is present over here, circled up on the patient's left shoulder. Then we'll move on to looking at the rotation. So if the distance between the sphinomous processes over here in the vertical line and the medial borders of the clavicles on both sides, and if this is equidistant, then we know that there is no rotation of this X-ray. So in this case there is no rotation. And then we'll move on to looking at the exposure, and exposure is determined by the visibility of the thoracic vertebra behind the heart. So in this film you can make out the vertebral bodies outline over there. That's inferior, that's superior, inferior, and then superior over there, and I can just about see the inferior one over there, superior there, and so forth. Okay, so I would say that this X-ray has good exposure. So let me just erase these, as we'll need this for labeling other important structures. Let's move on now to the airway in a different color. So as you can see, this is the outline of the trachea. Comment on whether it is central, which it is in this case. And you can just about make out this bit. So that's your trachea. This is the carina, the area which is causing the division of the airway into the right main bronchus here and the left main bronchus over here. Okay, and also if you look closely, you can also see the bronchus dividing into the right upper lobe here. So once you're happy with that, have a look at the hilar regions over here. Comment on whether if you see any lymphadenopathy on this side, as you can see in sarcoidosis, hematological malignancies, or even in pulmonary hypertension, you can see engorged vessels. So I'm happy with the airway. It looks good so far. And also have a look at the lung markings. You can see these streaks of white over here, and they usually extend all the way to the chest wall. In this film, they're slightly difficult to see, and I suspect looking at it, it does appear a bit hyperinflated, and we'll find out if it is by counting the ribs in a moment. So that's the airway, and we can then move on to looking at the bones. So comment on the clavicles over here. This is the outline of the clavicle, both sides. You're looking at the glenohumeral joint over here. Got the scapula, both sides here. Okay. Let's have a look at the ribs. So we need to count anterior and posterior ribs. So starting from the anterior ones, we've got the first rib there, second, third, fourth, fifth, sixth, seventh, and then eighth. And then it's easier to count the posterior ribs. So we've got the first one there, second, third, fourth, fifth, sixth, seventh, eighth, ninth, and then finally the 10th one. And the rule is if you have more than 6 ribs counted anteriorly and posteriorly more than 10 ribs above the level of the diaphragm here, then you know that this is hyperinflation. Although it's borderline with the posterior ribs, the anterior ribs are sufficient to confirm that this lung is hyperinflated. Okay. Also have a look at any vertebral compression fractures in the thoracic vertebrae over here, and you can also look for any fractures of the ribs or any lytic lesions in any of the other bones. Okay. Let's have a look at the cardiac outline and the great vessels now. This bit can be slightly challenging, but with frequent practice and understanding, it'll become easier. Let's have a look at the right-sided circulation. So this is the region of the superior vena cava. That's going to drain blood into the right atrium, which is down here. So you can see the outline of the right atrium there. And from below, this is the region of the inferior vena cava. And they're both going to empty into the right side of the heart. Okay. And then this is the region of the right ventricle. So the important bits to remember are the left and the right heart border are comprised of, on the right side, the right atrium, and on the left side is the left ventricle. So just keep these two facts in mind. And also on the right side, we have the right pulmonary artery, the region of the right hilum there. You can see this prominence. I'm just going to draw it again for you, or you can even rewind the video to have a look at this prominence over here, and that's the region of the right pulmonary artery. Okay. And on the left side, this bulge over here, you see, just drawing out the outline for you again, this is the region of the left pulmonary artery, and this is coming out from the pulmonary trunk over here. Okay. This knuckle over here is fairly obvious. This is the arch of the aorta, and you can see that you can trace its outline. And I've stopped over there just to show you that this is the descending aorta over here. Before moving on to looking at the diaphragm, it's also important to have a look at the cardiac diameter in relation to the thoracic diameter over here. This needs to be less than 50% of the thoracic diameter in a normal X-ray. If it's greater than 50%, then this might indicate cardiomegaly, most likely secondary to congestive cardiac failure. Also, this is the cardiophrenic angle on the left side, and this is the one on the right. Looks nice and sharp. There's no blunting secondary to an effusion. Moving on to the diaphragm. This is the outline of the diaphragm. Let me just use another color here. That's the one on the left. In normal individuals, the right hemidiaphragm is elevated compared to the left because of the liver over here. And the costophrenic angles over here are also nice and sharp, well defined, although they might be blunted in a pleural effusion. Underneath the left hemidiaphragm, we see some air over here, and that's the gastric bubble. And then finally, looking at everything else, you can look at the soft tissue of the thorax over here. You can see dark grey shades over here. This is likely to be fat. You're looking at the neck over here on the top. You can see any surgical emphysema secondary to either an esophagoscopy gone wrong or blunt trauma or penetrating trauma. Similarly, on the right side, you can also have a look at the soft tissue and appreciate any abnormalities that you can find. You can also see, especially in ICU patients who have an endotracheal tube, you can see that in the trachea. You can see a central line going towards the right side of the heart, and you can see ECG leads, pacemakers, and so on and so forth. So that would come under E. Okay, so to summarize, I think this is a pretty good method of interpreting chest x-rays. It is thorough and it is comprehensive, making sure you don't miss out on anything. So once you have these basics on board, we can then move on to look at some of the common pathologies that we encounter in everyday clinical practice. So that concludes today's talk. I hope you found this video useful. Leave any comments or questions down below and I'll do my best to address them. Thank you.